Good morning from the annual meeting in San Diego. We're pleased to be here today with Dr. Zaina Al-Mohtaseb. Thank you so much for being with us, Zaina.
Thank you for having me.
So, Zaina, this morning we have a really interesting topic to go over, which is cataract surgery with corneal pathology. There's a lot of things I think that can cause a cloudy cornea that affect the cataract surgery. Can you introduce the topic by spelling out what are some of the etiologies here?
Sure. So what I wanted to talk about was sometimes patients have corneal scars, whether it's from trauma or from previous corneal ulcers. You also have patients that have things with corneal limbal stem cell deficiency, Stevens-Johnson, that really creates a cloudy cornea and difficulty with seeing. And then you have a third group that have corneal pathology, such as Fuchs dystrophy, for example.
Mm-hmm. And so tell us, Zaina, how do these various pathologies affect our IOL calculations and our cataract surgery intraoperatively?
Yeah, so there's two main things that you worry about when you're doing these types of cataract surgeries. One is, how do you pick the IOL? You have, for example, corneal scars. I do a lot of the cataracts after open globes for young kids, for example. So, one thing that we talk about is potentially using the other eye for the measurements, especially for the corneal measurements. And then the other thing that you can do is actually doing an average corneal measurement, such as 44.5, for example, so that then you can tell the patient they might need a contact lens afterwards, or you can deal with the refractive error. And then also intraoperatively, the things that you worry about is, how do you do the cataract surgery? Mm-hmm. It's hard to see, just like it's hard to get the IOL calcs, and I talk about different ways that can help you during that surgery.
Well, let's dive right into that, Zaina. If you have a cloudy cornea that has a scar or perhaps Fuchs dystrophy, what are some of the intraoperative tips and techniques that can help you?
So a couple of pointers. The most important thing is to always stain the capsule with trypan blue. I would say doing the rexes is the hardest part when you're actually having that corneal scar, for example. Mm-hmm. The second thing is you want to start away from the area where there's scarring. And then that way you can start the rexus and try not to re-grab in the area where there's a scar. The second thing, I have a lot of patients that come, for example, that have Stevens-Johnson or other etiologies, that it's the whole cornea is very cloudy, and trypan blue is really not sufficient. And what I utilize now is actually endo-illuminator, which is a light pipe that you can put through your paracenteses to actually illuminate what you're doing for that rexus and for the rest of the case.
That's a really great pointer, and I'm glad you brought that up. I wanted to ask also about some of the technologies that can be add-ons to cataract surgery now, such as femtosecond technology or other ways for nuclear disassembly, such as the MyLoop. Mm-hmm. How do these play a role when the cornea is cloudy?
Right. So I think you can use these technologies to help you. Sometimes if you're able to do the rexus using the femtosecond laser, that would be wonderful, but sometimes it's hard going through a scar. Mm-hmm. The MyLoop has been a great addition because a lot of the times you're just not being able to see so that you can phaco, and if you have the MyLoop going through and cutting it into 4 pieces where you're just aspirating and removing the nucleus, it's really excellent.
Well, let's talk a little bit about IOL selection. Mm-hmm. You brought that up a few moments ago. If you have a patient with a corneal scar that has irregular astigmatism, is that patient a candidate for a toric implant, for example, or a multifocal or extended depth of focus implant?
So that's a great question. I'm very conservative when it comes to those kinds of patients. Anybody with irregular astigmatism, I really don't want to put a premium lens. Neither the toric lenses, especially because I know that post-operatively I'm going to get remnant irregular astigmatism, and then it'll be tough trying to put a hard contact lens in a patient that has a toric IOL. Same with multifocality. It really does, you want that pristine cornea. We even talk about ocular surface disease and staining, so imagine if you had a corneal scar. So from my perspective, those really aren't good candidates for it.
That's a great point. Let's shift gears for a moment, Zaina, and talk a little bit about combining corneal surgery with cataract surgery. If you have someone with a really dense corneal scar or really dense Fuchs dystrophy, are these patients better off having sequential surgery with cataract surgery and cornea surgery at a later date, or are they better candidates for combined surgery?
So that's a great question. I'll start with the lamellar corneal transplantation. So there's good data out there where they compare doing combined DSEC and cataract surgery or DMEC and cataract surgery versus just the corneal transplant. And they noticed that there wasn't an increased risk of dislocation or any other issues or endothelial cell loss, which means that you could do either one. So the one nice thing about doing sequential surgery, and when when I say sequential, I mean doing the corneal transplant first, clearing the cornea, and then doing cataract surgery. What's nice about that is you can have better refractive outcomes because then you have stability of the cornea, you know what remnant hyperopic error there was, and then pick the correct IOL for that patient. But doing a triple procedure, doing the lamellar along with the cataract surgery at the same time is nice. It's one surgery. It avoids for the patient to have another surgery. And we've noticed that on average, the hyperopic shift is very small. So if it's not a patient who's considering a toric lens because of significant astigmatism, I think it's really reasonable. Most of my cases are done at the same time. It's a little bit different with corneal transplantation for full thickness penetrating keratoplasty. The issue with that is we're a lot worse with IOL calcs. There's data that shows that it's less than 50% are within 2 diopters if you're doing the surgery at the same time. But again, you have to take into consideration the patient. Do they have the ability to wait, do penetrating keratoplasty and wait about a year for suture removal and stability of the cornea prior to doing cataract surgery? So
That's a great point, Zaina. I want to flip that around and ask you, what about the reverse order? What about doing cataract surgery first and then the corneal transplantation subsequently? Does that sequence ever play a role?
So I think that's a great point. The key is if the gutata or the corneal pathology is not that bad, that you think that doing cataract surgery is enough for that patient to be functional and to see well. For example, in a 90-year-old patient who has mild gutata, I think it's very reasonable. If they already have corneal edema or significant gutata, to me, I would definitely want to take care of that also. In terms of corneal scarring, if it's a really dense corneal scar that even just removing the cataract and even with a contact lens, a patient's not going to see, you have to deal with the corneal pathology part too.
Right on. Well, Zaina, this has been such a great discussion for us this morning about how to approach cataract surgery in patients with corneal pathology. Thank you so much for sharing your expertise, and thank you to our live audience as well for your support.
Thanks for having me on. Appreciate it.